Good morning, everybody. Can you hear me? Yes, okay. I'm Fiona Baumer. I'm one of the epilepsy doctors at Stanford at Lucile Packard Children's Hospital, and I really appreciate having the time to get to come and talk to you this morning. This morning I'm going to be talking about a condition that has many acronyms, most common of which is ESES. And I wanted to start off by seeing how many people in the room have been personally affected by this disorder. Okay, so we have a room full of experts. We only have 2 purple chairs, so we'll have to take turns in that. But ESES is a very rare condition affecting about 0.5 to 1% of children with epilepsy, and about 1 in 100 kids have epilepsy. And so today I'm going to talk to you a little bit. I'm going to give you an overview of what the condition is, about what we know about potential causes, and what current treatments are. And then I'm happy to talk about any questions you have and answer them as best as I am able. A lot of the answers are we need more research, and we're trying to figure out how to do that in the most effective way given how rare the disorder is. So let me start off with a little history. In the 1950s, there were 2 doctors in the St. Louis Institute for the Deaf who noticed that there were children who were there in this Institute for the Deaf, but weren't actually deaf. If you made a loud noise, they startled, they responded to noises, but they seemed selectively unable to understand language or noises that carried meaning, like a telephone ring. And what they found in common with these children were that they had a history of a few seizures and a very abnormal EEG. Fast forward to the 1970s, Dr. Tasserini described a group of children, some of whom had significant cognitive issues, who had this unusual sleep pattern. And you can see why art was never an option for me. What they found was that during the day, they might have what we call spike waves, which are, when we look at an EEG, which is this collection of squiggly lines, these really big spikes of, literally spikes in the EEG. And although they had a few spike waves during wakefulness, when they went to sleep, almost the entire EEG was filled up with spike waves during all parts of sleep except for the parts where you're dreaming, except for REM sleep. And at that time, he described something called electrical status epilepticus of sleep. And a few years later, he also recognized that some of these children had regressions in their abilities, in their cognitive abilities or language abilities, or sometimes even motor function. And so he changed that E to be encephalopathy with status epilepticus of sleep. And in the last 40 or 50 years since that was described, we have lived in a little bit of an alphabet soup regarding this diagnosis. So in the 80s, they introduced the term CSWS, continuous spike waves in sleep. And then there's another term, Landau-Kleffner syndrome, which is commonly used. And what do all of these terms mean? In the, not that long ago, in the last 10 years, they did a survey of child neurologists, and people couldn't agree. So I say that because these terms get thrown around a lot, and it can be very confusing in that we don't always have an agreed upon perfect set of criteria for these diagnoses. So I'm going to tell you, I think what in the United States at least is largely agreed upon now, which is that there is an EEG finding, which is this activation of spike waves in sleep, and many people will call that ESES. Landau-Kleffner syndrome is a whole syndrome or disorder associated with this EEG finding. So this EEG finding is part of it, but children tend to have language regression. And people often use this term, the CSWS, for children who have behavioral changes that are not just isolated to language. So more acting out type of behaviors, attention, significant cognitive problems. And so that's sort of a brief overview of these terms and how we are using them today. But there is a lot of fluctuation, and so you may have heard something slightly different from your physician, and it's just because that this is sort of the state of things. The second question, or I should say 3 things that make it sort of challenging to describe and understand this disorder, is that we don't have perfect agreed upon criteria for what counts. And there's 2 main components, right? We have this EEG change. And originally they described that if greater than 85% of sleep, so 85% of those seconds that you're asleep have these spike waves, okay, then you have ESES. what we've recognized, though, is that it probably doesn't have to be 85%. There's fluctuations from night to night, from EEG to EEG. And different doctors over different centers have looked and described patients who they think have this disorder with 50% of sleep involved, with even as low as 25% of sleep involved. So we don't have a firm cutoff criteria, although I think if you talk to most physicians, I'm part of an ESES group of a bunch of pediatric epilepsy centers in the country, and I think 50% is sort of more where we're thinking. The second question is about the changes in behavior associated with this pattern. So there are people who might have this pattern and not have any changes in behavior. But what we really want to see to have you have this diagnosis is that you've had some type of developmental regression, so maybe lost some type of language, or a stagnation where it seemed like you were developing and then it stopped. And when we checked, we saw this EEG pattern. And those are patients who we think might benefit from treatment. Because whenever we're treating children, we want to be very careful not to use medicines that every time we use a medicine, it has the potential of causing side effects and problems. And so we want to be careful that we're using these medicines for people who are going to get a benefit from them, to make that side effect profile, to make that treatment worthwhile. So that is the second question, is how do we best decide who meets that behavioral criteria? And what physicians from multiple centers have noticed is that there are probably 2 to 3 groups of behavioral changes. There are kids who have a clear regression. The parents come into us and say, my son was talking and all of a sudden you can't understand, his speech is very challenging to understand, or he's just lost all of his words. And that's a more clear-cut picture. There are other children who weren't developmentally typical to begin with, and they come in and we see this pattern, and the family says, maybe there was a period when development was taking off and then it stopped. And one of the challenges is figuring out how to measure development and then measure development again after treatment to see if there is a change. And that's something that we have to work very closely with psychologists to achieve. So that is some of the definitions. Right now, I'd like to move on to talk a little bit about what we think are causes for this disorder, but I wanted to stop to see if there's questions from this perspective.
Were you talking about the difference between CSWS and LKS?
I was talking about how there's it's a challenging set of diagnoses because we have used these terms a little bit loosely over the decades, but how in general right now we think of Landau-Kleffner syndrome, LKS, as behavioral changes in language associated with this EEG pattern. Yeah.
I have a question. I don't know if it's the right time for it, but the language regression that we see with LKS, my understanding is that with CSWS, that the regression is more global. And I wonder if the language issues, though, are the same. Like it's the same language issues as with LKS, but plus regression in other cognitive areas as well.
That's a great question. I actually don't know the answer specifically to that. Often when someone, just to recap, we had said CSWS is generally used for these more global regressions or children who have more global problems to begin with. So in my experience, children who have come with this diagnosis, CSWS, often were not developmentally on track and then had worsening of behaviors, typically being the thing that brings them in, making it more difficult to sort out because the language regressions that are described in Landau-Kleffner syndrome are specific processing issues of understanding meaningful noise, understanding language as being something that carries meaning. That makes sense. Like, if someone is just sitting there making noise at you, you have to know the language to understand, oh, that noise is actually them saying, hello, would you like this cup of coffee? So children with CSWS often don't have as developed language to begin with, and so we're often looking more at behavioral changes.
Well, I've read a lot of literature about how ASL can be a good communication method for kids with LKS, and it's all referring to LKS.
Yeah.
And I wonder if for a kid with CSWS who did have communication difficulties to begin with before the ESES even started, I don't know whether to advocate for ASL with the same rationale that's used to explain why ASL is a good fit for kids with LKS?
So that is a good question. Can I come back to? I'm going to go through a few, and also I have to think about that. I mean, I think that oftentimes in terms of treatment, and the reason I'm saying I'm going to come back is because at the end I'll talk to you about what's known as treatments for this, and you'll see that there's a lot of space for us trying to understand what would be best next steps, and supportive treatments fall into that as well. Okay, so I'm going to move on for just a few minutes to talk a little bit about what the general causes of this disorder are. So what we found is that about 30 to 50% of children who come in and have this EEG finding and behavioral changes have a structural problem with their brain. Some of the most common problems are something called polymicrogyria, which is an abnormal, the surface of the brain, the cortex, is abnormally formed. It has too many little folds, and this is something that usually happens during fetal development. And in particular, children with Landau-Kleffner tend to have that around the big, I thought I was going to get a model brain. My brain pictures are even worse than my spike pictures. Around the folds on the side of the brain, so around areas that are important for language. A second major cause are injuries that affect the thalamus. The thalami are the bilateral, they're in both sides of the brain, deep in the brain, and they're the way stations. They take all of the sensory input, auditory input, tactile input coming in, motor, and then they coordinate it with the surface of the brain, all that information going out. And so they're relay stations. They're really important for that, and also for coordinating sleep. And so children who have had injury to the thalamus, particularly in the neonatal period, for example, a stroke or a bleed in the thalami, represent a big group of children who have this disorder, and are people at this point now we know we have to pay attention to see if this develops. And even studies more recently have shown that subtle differences, not a major injury that we can see, but hints that there was an injury, for example, that one side of the brain, one thalamus is smaller than the other, are risks for this disorder. So that's the first category. The second category are genetic changes, and this is a really exciting field that's developed in the last 7 years. So in 2013, there were 3 major studies discussing genetic changes in this disorder, and what they found is that about 20% of children who don't have a structural problem have something called a GRIN2A mutation, which affects a channel in the membranes of the cells in the brain, the neurons. Yeah. And this channel is important for something called glutamate. Glutamate is the chemical in the brain that's important for excitation. And this channel basically lets one cell know that the other cell is saying, okay, get excited, fire. What's very interesting about these mutations is that they're not all the same thing. So some of the mutations cause that channel not to work well. Some of the mutations cause that channel to work too well. And the reason I say this is exciting is because if we can identify problems like this and then understand how those are affecting the cells, it opens the door for new therapies. And for example, and I'll talk about this a little at the end, there are a few drugs that we already have, even the drugs in cough syrup, that affect these glutamate channels and decrease their transmission. So for children who have mutations that cause too much excitation at that channel, it's possible that we can use drugs we already have to try to treat this condition. So that is the second major group. And then, so even though this is about 20%, there's been 10 other mutations, single mutations associated with ESES. Many of them have also been in other channels, channels for potassium and sodium that are important for that balance of excitation and inhibition in brain cells. Other mutations that we've seen are important for the way that that cells in the brain interleave with each other, making synapses, which is how synapses are where cells communicate. And a third set of channels are important for the way that cells stick together, the adhesion. These ones have already been described in autism as enriched in children with autism spectrum disorder. And this is a good bridge because these type of channels are thought to, or these type of mutations may affect the way the brain responds to inflammation. So the first category of problems I said were structural, that we can see on pictures of the brain. The second were these mutations. And the third, and it's sort of a much more vague category, is inflammatory disorders. The reason that we suspect inflammation may be important for ESES is the fact that one of the most effective treatments that gets rid of this EEG pattern is steroids, which decrease inflammation. We really haven't, we're really at the cusp of starting to do this research. So there's been at least one study looking at inflammatory markers and showing that that they are elevated in children with ESES compared to controlled children. In particular, a marker called IL-6, and there's actually a drug that exists that targets IL-6, so it's another area where it's potentially interesting for future therapies. But again, that is an area where we definitely need to understand better because we don't, for example, have an inflammatory disorder described that causes this problem. So the third thing I wanted to talk about is the current treatments and where we can go from here. So, sorry.
I'm sorry. Where does cortical dysplasia fall? Is that more?
That's a structural problem, yeah. And there may be mixes of things going on. There probably are, as everything is always a little bit more complex than meets the eye.
Yeah, I used to know if it was structural or inflammatory.
Yeah. But there are a lot of, so cortical dysplasia, there's often a lot of inflammatory cells associated with that. So again, there may be a little bit of a mix. Yeah. So I know that when I started, a lot of people here have been affected by ESES, and so I'm sure you know these therapies really well by now. But currently, what we do, we take one of three tactics. The first is to use typical seizure medicines that are very good at suppressing spikes. And those tend to be valproic acid, or Depakote is the other name, levetiracetam, or Keppra, sometimes a medicine called Acetazolamide, or Zerontin. And we use those to see if we can get rid of the spikes. The second therapies are high-dose benzodiazepines. So diazepam, which is the same medicine as in Diastat, given at a high dose by mouth at night, or high-dose clobazam, or Onfi is the other name. And then the third major category is steroids. And again, high dose, we do 1 milligram per kilogram of your body weight, so that's quite a dose. And if you're in that first category where we're using a typical seizure medicine, once we start it, if everything goes away, oftentimes we're more inclined to let you stay on that medicine because it's a medicine we keep people on for months to years anyway. But the other two strategies are ones that we try to use for brief periods of time, for sort of on the order of 1 to several months, and then wean you off to see if this comes back or not. So that is right now the state of the field. What's been challenging is this is only 1% of children with epilepsy, so it's very hard to do appropriate studies and actually report what is effective. So the gold standard of knowing if a therapy is effective is doing something called a randomized controlled trial, where you get medicine A or medicine B, or medicine A versus a placebo, and then you see, is there actually improvement? What all of that data, what those treatments are based on is centers reporting, well, I saw 10 kids over 10 years, and this is what happened when we used this medicine. And that's just the state of the field because there are not very many patients in any one given geographic location. The biggest study that's been done is a meta-analysis looking at about 600 different children reported through these studies. And what they found was that 80% of children responded to steroids. So steroids seem to be the most effective. sorry, and the one other thing I didn't say is one of the very effective treatments is if you have a clear lesion that can be removed surgically, that is equally effective to steroids. And so a surgical resection is a good option if that is something that works based on the cause of your ESES. The high-dose benzodiazepines were also quite effective at about 70%, and the anti-seizure medicines at about 50 to 60%. Again, the problem though with those other, the high-dose benzodiazepines or the high-dose steroids is that when you come off, a good chunk of patients relapse and have this EEG pattern come back. And in terms of trying to get to a better answer, in Europe, they're doing a multi-center trial right now. They began enrollment in 2014, and they just closed enrollment, to my understanding, this June, and so should be reporting results in the next 1 to 2 years. And that was a study comparing clobazam, or Onfi, with steroids. And so the things that have risen to the top, to compare them head to head and see who responds, how long do they respond, how does their cognition improve, and what are their side effects from these medicines. So we'll have a little bit more concrete data in the next couple of years. In terms of next line therapies though, I brought up a few different causes, and so people have been trying to think, what have we learned about pathophysiology and how can that help us? And so for example, I was saying with GRIN2A, it's a mutation that affects glutamate channels. And so people have tried something called amantadine and memantine, as well as dextromethorphan, which is that medicine in cough syrup. These are all anti-NMDA channel blockers, and they have found some efficacy, but these were not really well done trials. This is people, trying it at their hospital with patients who have failed the typical therapy and seeing if people improve. And there were some promising results, but we don't have definitive answers on that. There's been another therapy available in Europe called sulfiam, which is something that changes the acid-base balance in your blood.
Sorry, can you repeat the name of that?
Sulfiam, and that has been effective for some people. It's used in a condition called Rolandic epilepsy or benign epilepsy with centrotemporal spikes, which shares many of the similar features as ESES, but you don't have as many spikes. You have these sleep-activated spikes, and you have occasional seizures, and you have some cognitive deficits, but it's sort of the mild end of that spectrum. And so it's used there for that very effectively. It's not available in the United States. In response, some of the physicians at Mayo tried a trial of acetazolamide, which is another medicine that does a similar thing as sulfiam. And again, this was not a clinical trial. They added it on to patients who hadn't responded to typical therapy. And they had very promising results in their study of, I think it was 20. And they tried to do a clinical trial at Mayo, but they had to close it because they weren't able to get enough enrollment. So that is something also that that group has, they've shared their experience and has become more considered now for people who are refractory to the typical therapies. And then I think finally, I didn't touch on it much, but surgery has always been a treatment option. For a number of years, people were doing something called subpial transections. And basically the idea of that is that within the brain, cells are designed in columns, are organized in columns. And they talk to each other in this vertical way. And the idea was to go in and cut the connections between the columns so that if one column was the source of those spike waves, it couldn't spread it to its neighbors. And because the connections horizontally are not as important for things like movement or language that we know about, it didn't have a terrible number of side effects. Originally, it looked promising, but at this point, it's rarely done because the evidence has not borne out that it's very helpful. So that was one type of surgery. The surgeries where if you have a clear lesion, if you have a focal cortical dysplasia, or if you've had even a hemispherectomy because you've had a stroke and you have a major lesion in half of your brain, those are quite effective with ESES going away in about 80% of patients. So those are quite good options if you have that. Those are most of the things that I prepared to talk about. There's a lot of other sort of interesting components of this disorder that I can speak on, but I wanted to stop now because I've said a lot and ask for your questions and see what you're most interested in hearing about.
Is there any doctor who's willing to write a prescription overseas for sulfonyl? Because acetazolamide is not the same, obviously. When we tried it, it's not as...
Yeah.
I talked to many neurologists and
Yeah.
was willing to get a prescription from Canada or somewhere in Australia.
So I guess I don't know, and I shouldn't speak out of turn because I've only ever written a prescription out of the country when I was a resident, and I was in Boston for residency, and it was for a different type of medicine for a different condition. We wrote for a drug in Canada, and I actually had talked to the parent organization for that, and they were the ones who helped me figure out how to best do this, and we did it that way. I think that people are often willing, and sometimes you may need to, like my one patient who's been on Sulfiam was a child of someone in the military and had come on Sulfiam, and so through those kind of connections we were able to get it and have it shipped here. So I think that, I don't want to speak for the doctors in your area, but I think it probably could be worked out. It might involve having to visit Europe to establish some type of relationship, or Canada with somebody. When we tried to get Sulfiam in Canada, it was challenging from from the Canadian insurance perspective. We weren't able to do it because that was an avenue we explored. But I think people would be willing to work with you, or willing to, if you're able to go to Europe, or especially as telehealth increases, try to find somebody to help you.
Asia as well. Japan is not there. I didn't have to see a doctor there.
Yeah.
But then I can't find anyone to talk to.
Yeah, I'm sorry. It has relatively limited side effects, so it may be worth exploring that to see if they could just ask if there's anyone who has a colleague in Japan and they could help sort of do that, but I'm sorry.
Did you say amantadine blocks the same channels as sulfiam?
No, so Sulfiam is a carbonic anhydrase inhibitor, so it changes the acid-base level in your blood. It works on the kidneys, so it's a different measure. And why that changes in epilepsy, I don't know the answer to it. It's been known we use it especially in something called catamenial epilepsy related to your menses. So it is a medicine that we do use, but a lot of our epilepsy medicines sort of were historic accidents. And
A lot of the medicines work so differently with different people.
Yeah.
My son started with benign Rolandic epilepsy and had irregular spike wave activity, and then ESES developed.
Yeah.
A few years after that, this was 7 years of age. He's 15 now. He's 0% spike wave now.
Okay.
His doctor at UCLA put him on amantadine.
And it helps that, or
My question is, here's the big mystery: is it going into puberty? Because sometimes
Yeah.
it resolves itself going into puberty, or was it the amantadine, or a combination?
so we were having a discussion about this earlier. For what we know is that people with structural lesions don't tend to have the same resolution if left untouched. Children with benign Rolandic epilepsy clearly do. We know that by 16, almost everyone has sort of outgrown the condition, and the EEG normalizes over time. And these children with...
You said, sorry, my hearing is...
Oh, sorry. No, and I talk quietly and blend into fans easily.
That benign Rolandic epilepsy eventually resolves itself?
It does. And then children sort of on the sort of middle of the spectrum of atypical benign Rolandic epilepsy, it's a little bit more of a question. It usually does resolve. Like this is a disorder that tends to be limited to children unless you have a clear structural problem. So the onset of ESES is between 2 and 12 to 14 usually, with the biggest peak being in 4 to 8 year olds. 4 to 8 year olds is the... Yeah. So there is probably, just based on that etiology for children where we don't quite know what the cause is, it probably, based on this pattern, probably there is genetic or multi-genetic causes, probably related to neurodevelopment, because we know the brain is doing its own big developmental sweep. And so something about the way that excitation and inhibition, or the way that synapses act during that time period, is altered. And once you switch to a more mature formation, that probably contributes to resolution. But we don't know what that is. These are hypotheses, but
I'm at an interesting
yeah.
place where I want to start to back off on the meds, and there are doctors that are saying, no way, don't accept the apple cart.
Yeah.
It's going well, and other doctors say, yes way, time to.
Yeah, that
So as a parent, I'm going,
yeah, and
doctor to doctor, seeing what everyone thinks about that.
we can't even agree on what the E means in this. So there's a lot of opinions. Yeah, and but that's why when I say that, like, there should be a number of these purple chairs here, there's a lot of experts, because everyone who goes through this represents not a small segment of the population. So your experiences are how we are learning and how we're trying to figure out what is best.
As for treatment, the only thing that helped my daughter was the ketogenic diet. And I wonder if that was part of if she had more of an inflammation type, because the ketones can lower inflammation, or.
So the ketogenic diet, we're having discussions about, there are a number of other treatments. So there's I think been 3 or 4 studies on the ketogenic diet in ESES. The largest of which was I think 50 children. And mostly it's been added on to other therapies, and there weren't a ton of strong results. But it's certainly something that if somebody is capable of doing, because it is a very challenging diet, we do recommend trying, because it for a lot of epilepsies and these epileptic encephalopathies, where we think that this activity, even though it's not causing seizures we can see on the outside, is causing cognitive changes, it does seem very effective in those types of disorders. So I apologize, I didn't mention that. I think the one other treatment that I didn't mention that has been more published on is Ivig, which is also an anti-inflammatory therapy, and the publications are pretty dismal. It doesn't look like it works based on what has been published. We've done a sort of a retrospective look at the last 4 years in numerous centers, and only a few people have tried Ivig, and it didn't work for them. But incidentally, I had a patient who did Ivig, and the ESES did improve. They were very steroid responsive, but they just couldn't stay on steroids forever. So there are therapies that we're trying to learn, we need to learn more about.
Can you just ask to try steroids? Like, are they just prednisone, like steroid?
Yeah, usually it's pred or methylprednisone, which is the liquid form. So yes, you can ask, and it's some centers. I'd say that in the United States, the people prefer to start with the high-dose benzodiazepines in general, but each doctor is a little bit different. So, for example, the person who's the head of the epilepsy center at Stanford is she's very committed to steroids. So I was trained to try steroids early on. But there's variation in practice. But yes, you can ask. And
She's been on all the medicines.
that I mentioned, but she's never tried steroids.
No, they've never tried steroids. And she had, when she was 4, her whole lymphatic system was swollen so badly that they thought her adenoids had grown back. And they did a CT scan, but it wasn't. It was just because everything was so swollen. It was so puffy that it pushed her ear tubes out.
Oh my goodness, I'm sorry. So steroids have more side effects, I would say, than the benzodiazepines or the seizure medicines, and they have more side effects that affect the whole body. And in general, we don't like people to be on these levels of steroids for long periods of time. But what we find is that even though 80% respond, at least 30 to 40% have it come back when we take the steroids off a month or 2 later. And so that, if I don't know your daughter's situation, but that's something that they always are balancing as well, is whether side effects from the steroids would be problematic with any other kind of medical condition, because that's a significant consideration.
I have heard of a different neurologist saying it's better to keep it steady, like maybe like 2 to 3 times a day in the mornings. The one that does a higher dose in the morning, but then one that does an IV.
Yeah.
I've done a 20 milligram per kilogram 3 days per month, which is the most effective.
Yeah.
They said it's not. So you need a steady dose. And everybody tells me so different. So what is your view on what
I have always done the steady dose, but I've had families tell me that the pulse dosing works really well. And in other child neurologic conditions like muscular dystrophy, when people are on chronic steroid therapy, they have fewer side effects often with pulse doses, like weekend steroids, or there's a variety of different ways of giving it. So I think, yeah. Yeah. Right. It is scary, and that is where we are. So that's not because your doctors don't know what they're doing. It's because that there's not a known answer. Like right now, we're just trying to say, are high dose benzodiazepines versus steroids more effective? That's where we are in trying to answer this question. We have sort of some history from all of the families who have been treated so far, but if we actually look at it in sort of a really thorough way. But so again, in my experience, I've always done the consistent steroids, but trying to get people off. But I've had people say that the pulse dose is helpful, and we've had discussions about that in the group that I participate in among physicians, because what we were trying to do is set up a common pathway across institutions. So even though we weren't going to do a trial where it was randomized, it would be if you went to Stanford or Denver or Boston Children's or CHOP, or UCSF, that you would all sort of fall into one of three pathways using somewhat similar medicines, so that if I like pulse dose versus my colleague who I work with likes pulse, we get rid of that small variation. We think about each individual patient, but we try our best to use one of these more standardized therapies, so we would have a better sense of what works, and so we could answer these questions a little bit better than just based on our own opinions.
So, do the steroids actually slow down the seizures too, or just the cognitive functions?
So the steroids, the goal of that is mostly to get rid of these EEG findings at night, and hopefully the other goal is to assess, if we get rid of this, what happens to cognition, and hopefully it improves. Steroids are not, to be honest, steroids help a lot of things, and so seizures can go down, but it's not an anti-seizure medicine. So if you're someone who has seizures too, you probably will be on a seizure medicine to address those, as well as the therapy to address this, the ESES.
And then so let's say we try that and it works, does that mean that the anti-inflammatory thing could be an issue?
Yes.
Can I ask for her to be, when I go back to see the neurologist again, can I ask for her to be tested for the IL-6?
So clinically, we're not doing that right now. But that's what we have to pull together as, for example, 10 years ago, we weren't doing any genetic testing, and now we are. So that's, I think, the next frontier of what we have to organize are what panels, what questions should we be asking, and how should we be testing? Because as I'm sure if anyone here has done genetic diagnoses, we get a lot of answers that we don't know what to do with, and we have to be very careful with those types of answers, because trying to treat those or trying to go after things can cause more problems than solutions. But that is what we need to work on, is trying to identify inflammatory causes. We need to work on a lot of things. That is one of the things we need to work on. Other questions? Yeah.
Is the treatment the same, more similar to steroids, if it's a presentation in almost adult?
So I think it depends on the scenario. We don't think of this as a disorder that has onset in adulthood. Yeah.
She was actually presented at 7.
Okay.
And we aggressively treated until she had more so like Alzheimer's.
Okay.
We did full steroids. We did it differently though. We did 1,000 disorder for 3 days in a row.
Okay.
And we ended up doing it every 4 weeks. She did that for 4.5 years.
Oh wow.
And then she was also on seizure medicines as well.
Okay.
But we did that for 4.5 years, and then unfortunately, going through puberty, hers actually got worse rather than getting better. And she
Okay.
started having tonic-clonics that were usually about 45 minutes long if they were untreated.
Okay.
7 to 8 with 100%.
sorry.
She ended up having surgery. She had a right frontal resection.
Okay.
Completely normal EEG for 3 years after that, and really no deficits, almost no deficits, which was great. And then just recently it came back. Now she's 17.
And so,
So she's still
is it the ESES? Yeah.
never stopped.
Okay.
She's been on seizure meds the whole time, and we got rid of her the steroids.
Okay.
She's still on very low dose monthly, just about 10 milligrams. So now I don't know.
I think based on what you described, one of the things I might consider is going back to think about the surgery again, because oftentimes, sometimes we don't have perfect surgical margins, and sometimes the things like dysplasias are more widespread than we realize on imaging. Of course, we can't see, like, we do MRIs and we can't even see all of the dysplasias on them. It's yeah. Yeah. No. I mean, it's certainly something that, again, you could try, but I think that it might be worth, especially in surgical cases, because there are such good outcomes if you are able to remove the lesion, that it's worth pursuing that. One thing that I didn't talk about very much, because I focused more on the clinical components of this, but part of the research is sort of, why does having these spikes cause cognitive problems? What's happening in the brain? And there's been a number of studies looking at PET studies, which are studies of how your brain uses sugar or energy. And what they find is that there are areas of the brain near where the spikes come from. It tends to be, again, that fold, the Sylvian fissure. Or sometimes people have spikes that are a little bit more posterior or frontal. Those areas get very hot. They use a lot of energy. But other components, like the frontal part of the brain, which is important for attention and controlling behavior, what we call executive function, actually tend to have decreased energy consumption compared to average. And then they look at studies looking at connectivity, and they see that areas where the spikes come from often become hyperconnected to other parts of the brain, and so theoretically could be disturbing functions there. And parts of the brain that we have these, if you can imagine, they're called resting networks. So if you're just sitting there and kind of quietly thinking, that network, the resting state network, is on. Those networks have decreased connectivity. So the spikes probably are sort of hijacking normal networks in the brain. And so things like PET studies, though, may also be helpful in trying to help identify areas that surgically could be helpful. That's not typically, if you're going through a surgical workup, that's how we use PET studies. They are also used in research in this condition, but it may be a crossover area where something subtle could be helpful. Other questions?
So were you saying, like, the sugar? I'm curious about that, because for sure for our daughter, it seems like if she has corn syrup, it almost triggers a seizure. Because I graph them. If she has corn syrup, there's within a 30-minute window, there's an increased risk for her
To have seizures.
seizure.
So when I'm talking about the sugar here, that's like a special marker that we use. Exactly, where it tells you where the brain is using this energy. But if that's the case, then you may benefit from talking to people who have tried the ketogenic diet or considering something like that, because those are the type of observations that make us consider things like the ketogenic diet.
My son is 11, and he's still spiking, but we decided to remove him a month ago.
Okay.
His processing speed increased drastically. Stopping on levels. He's doing so much better.
Oh,
But
good.
he's still language he's still got an infected. So I don't know if I should go after that and treat it, or just let him continue at this point, since it's already getting talked to. I don't know what to do at this point, so that's the only reason I'm here is to talk more as much as possible.
Yeah.
Neurologists that they just don't even bother with this, but just don't even do EEG anymore.
For the spikes.
He's
Yeah.
fighting for outcomes. It's like forwards of what we know. It's a lot.
Well, I think I apologize. I didn't come back to your question, but I think that draws, there are sort of two components there. Is how do we support children, and how do we teach them other ways to express themselves, to use language, and that's an area that has not been well researched within this sort of condition globally. But he's fully verbal.
Because he speaks almost like that's his second language.
Okay.
So he has that's like a role in the same subclass. He makes mistakes. He has problems like saying three and things like that. But he's in Gen now, and he's keeping up with instructional aids, and everything else is doing okay but the language. That's the only problem is that he can't comprehend. So he's in probably second grade reading comprehension level. But everything else is just great.
Well, I don't want to give like specific medical advice, only because I haven't seen or examined your children. That is a really hard call, and I think that's one of the really hard things about this disorder. For example, I have patients who had sort of significant symptoms of autism, language problems, social problems, and we found later on that they had this ESES pattern, and it raises the big question of, do we treat this? I have patients who are very functional, who have straight A's in school, and they for some reason come in and have an EEG, and we see this pattern, and then we say like, are they missing something, and we're just letting it slide, and it's really hard to know what the answer to that balance is. I think that in that sort of, it begs the need for testing that is adequate. So, if people have very selective or small difficulties in a certain area, general testing may not pick it up. So it may not be the best measure for these kind of things. If they have big problems with communication, it also is difficult because a lot of neuropsych testing depends on some component of language. So it may not be possible to sort of measure over time, and we're relying on people sort of saying, it seems better, he's acting, his behavior is improved, he does seem to be communicating more. And then the third thing is, if we do testing, and even if you're in that sweet spot where we can pick up sort of problems, there's issues where if you do a psychological test on month 1 and month 5, you have what we call like retest problems, where you've already been exposed to that test, so you do better on it the second time. So we have all these biases. So we really need to work on that. There are some tools that have been used that you can take multiple times to try to capture that. But when it comes to specific problems, I think the main question is, if you get rid of spikes, do things seem to get better with the therapies we have available? If you can't get them better and you see them get worse, then we're probably not doing any good for your child to just keep pursuing that. And I agree that that's not our goal. Our goal is to make sure that balance is as sort of perfect as possible. But these are the yes. We see a lot of children who fluctuate, and we do tend to be pretty aggressive about trying to treat the spikes, because we do see parents often they report the fluctuations. If someone doesn't report a fluctuation, we don't tend to just continuously check EEGs. We check them intermittently, but we don't check them just for the sake of checking them. We check them if there's been concerns.
Is there a higher likelihood of those kiddos with ESES to go into status?
Into clinical status? Not really. It's actually, so there have been reported cases of things like SUDEP, but to be honest, the seizures don't tend to be that significant of a component compared to a lot of other epilepsies or epileptic encephalopathies. Children with Landau-Kleffner, for example, may never have had a seizure, or they'll have one or two. Children who sort of got categories as CSWS tend to have more seizures, and they're often a little bit more difficult to control. And some kids have quite challenging seizures to control, but that's not as big of a part of this picture usually. So.
So it's also the global versus local as well. Like the severity of the disease, not the percentage, it's like where it's occurring.
Where it's in the brain. Yeah, so in Landau-Kleffner syndrome, it's traditionally described in the temporal regions, which is the part of the brain associated with receptive language, understanding what is being said to you. And in CSWS, people have said it tends to be more frontal, it tends to be more global. For most of these conditions, the spikes are often just in like one half of the brain, in one hemisphere during the day, and at night we tend to see this synchronization. Where you see them on both sides at once, even if one side leads in. And that's probably related to the effects on the thalamus. So what the current sort of thought is that it's not that the thalamus or the connection between the thalamus and the cortex is what causes the spikes, but there's something probably in the surface of the brain, the cortex, that starts the spike, and the thalamus, particularly if there's some kind of injury, allows it to sort of go pretty quickly to both sides.
Do you prescribe dialects for these some of the patients in your hospital?
Yeah, so currently no, but I'm guessing that's going to be coming up as a question. I was last night I was spending some time looking to see, because I was guessing that would be one of the questions today, and it hasn't been, it's not been used yet in a trial. I did meet one family today who says that they've had a good response with it. It's only been available for a year now, so it hasn't quite made its way in there, but I'm sure it will be and will be explored.
If they could be on like Onfi or something, this is what I get, so that might be the one piece of it.
Yeah, it could be, yes, exactly, it could be that. What we've seen is that in our center we have tried a number of different seizure medicines. So the traditional treatments are you start a medicine, you're on it for a month, and then you wean off. But for example, I have colleagues who always put somebody on a typical anti-seizure medicine like lamotrigine to try to prevent it from coming back. That's not how everyone does it, but it's just one way that some doctors do it. We have experimented with not just the ones that I said today, but we've used Fycompa, which it affects a different glutamate receptor, the AMPA channels, with some success. So I think that people who have this condition probably, a subset of them will respond to a variety of different medicines.